This should only be performed by those who are competent in this procedure or under the supervision of those who are. The indications for endotracheal intubation are large, but normally results because of respiratory failure, which can be hypoxia because of a bacterial pneumonia or a COVID-19 infection, or hypercapnia, which is high carbon dioxide levels, maybe because of asthma. A patient may be apneic and could be in cardiac arrest. They might have a threatened airway because of edema from smoke inhalation or anaphylaxis, and intubation provides a patent airway. They may also have altered consciousness and may require airway protection to avoid aspiration of gastric contents where their cough and gag reflexes are not working as they should, and also for secondary protection in patients with neurological diseases to maintain appropriate normal levels of oxygenation and carbon dioxide via mechanical ventilation. However, there are complications that can happen because of intubation. These include esophageal intubation, which unrecognized will mean that the patient doesn't get oxygen delivered to their lungs, aspiration of gastric contents, airway trauma, all of which can lead to increased risk of hypoxia in the patient, and worse, a can't intubate and can't oxygenate situation, which is a medical emergency and would require the patient to have front of neck access performed. More commonly is dental injury in about 1 in 100 patients, but doesn't carry the same level of risk to the patient. To minimize these, we have come up with checklists which should be performed prior to intubating a patient so that everything is ready and prepared in advance, including needing to prepare for failure. So we start by preparing the patient. We want them to have adequate intravenous access. We want them to be sat up as much as possible. And we want them to be breathing on oxygen so that they are well pre-oxygenated and have a full level of reserve. That means that for 3 minutes they need to be on 100%, and ideally, if there is then tidal monitoring of oxygen, that this achieves more than 85%. An airway assessment should be performed, and if this is considered difficult, then the patient should have extra care taken when trying to intubate them. The patient should be well resuscitated to avoid hypotension or a fall in blood pressure because of medications needed to sedate the patient. An NG tube can be passed to reduce the chance of aspiration by decompressing gastric contents. And it is worth knowing what the patient's allergies are and potassium levels if succinylcholine is to be used. The next thing to do is to prepare the equipment. There is a lot of equipment required for a patient to be intubated. They should already have monitoring of their saturations, ECG, and blood pressure. We definitely need to have a waveform end-tidal carbon dioxide monitor, which essentially will allow us to make sure that the tube is in the right place once it has been inserted. What we want to make sure is that we have 2 endotracheal tubes. These should be both checked with their cuffs to make sure that these inflate, and that is done by applying a syringe of air to the pilot balloon. And then making sure that the cuff at the end of the tube remains inflated, because this is the seal that we will put within the patient's trachea and makes this a definitive airway. Prior to intubation of the patient, we would want to remove any air that was in the cuff once it had been checked. The next thing that we need is a set of laryngoscopes. These will allow us to look down into the patient's oropharynx by using a light source and a handle that can manipulate the patient's jaw. We would want 2 of them to be available with their batteries fully charged and their light sources checked to make sure that there is a backup in case one fails. A video laryngoscope is a good idea to have available because this will allow us to intubate a more difficult patient. It has a video screen that allows everybody who's present at an intubation to see where the light source is and what the patient's anatomy is, while also having a different shape of blade that allows you to pull an anterior larynx further forward so you can see more. You want a bougie or a stylet that will help guide the tube into place if it will not go in easily by itself beyond the vocal cords. This needs to be inserted with care because it can cause tracheal disruption. You want working suction to be available because that will enable you to remove any secretions from the oropharynx and avoid them going into the lungs. This can be either with a soft suction catheter or a Yanker sucker. You would want additional airway adjuncts to be available. These include Guedel airways and the appropriate size selected for the patient by measuring from the incisors to the angle of the jaw, and that will enable you to oxygenate the patient well after they have been induced, if they have a very heavy jaw, and likewise to have supraglottic devices available, such as these eye gels. These eye gels can be easily inserted into the oropharynx and then into the pharynx by sliding them in smoothly to sit over the trachea and enable oxygenation and ventilation. They are not definitive airways, however, because they do not go beyond the vocal cords and do not have a firm seal. We would also consider having drugs available. If the patient is awake, they will need to be induced with a sedative and also have neuromuscular blockade for paralysis. A regimen that could be considered is 3 mics per kilogram of fentanyl, 2 milligrams per kilogram of ketamine, and 1 milligram per kilogram of rocuronium. That would enable us to have intubating conditions within a minute, and all of these are given intravenously via the cannula that you've already checked for the patient. The next thing to check is the team. You need as a minimum 2 people to intubate a patient safely. 1 to be the intubator and 1 to be the assistant. The assistant can hand the equipment over to the intubator and can also be nominated to give drugs. However, it is helpful to have other people available, for example, one who can keep time so that the patient does not have prolonged periods of apnea, which can lead to desaturation. If the patient has been well pre-oxygenated, then they should have 8 minutes of apneic time, during which their saturations will not fall. It is also useful to have a pair of hands to provide manual inline stabilization of the cervical spine if this is a trauma patient, so that no further injury to the cervical spine can occur. The last thing we need to prepare for and consider before we intubate the patient is what if we have difficulty? Could we wake the patient up? Could we reverse some of the medication that we have given them? Or do we need to think about introducing the supraglottic devices that we have available, managing with a face mask valve ventilation using adjuncts such as the Guedels, considering fibre optic intubation, or indeed front of neck access if we enter the can't ventilate, can't oxygenate situation. That usually is a scalpel, a bougie, and a tube. So you would just need a scalpel in addition to what you have available. Now, we will move on to demonstrating how to intubate the patient.